Good morning, everybody. I hope you enjoy the morning of Bangkok, the first day. Today we are full house again. This session gonna be about injectable complication, safety first. What should we do to make the patients safe with our practice? And that we gonna, share our case study from our university in Thailand, and we will show you what cases that we have, and we share experiences that we actually have been experiences in these few years. Okay. First, we start with our first speakers.
Okay. I'm Dr. Natasha Juraratanaporn. I'm a dermatologist based in Bangkok, Thailand. So actually, I work at the same place with Dr. Ajima. Okay, we work at the Ramathibodi Hospital. It is a university-based hospital in Bangkok. So our center, I have to give you a short background first. Our center is a referral center of filler complication cases all over from Thailand. So we selected very difficult cases and interesting cases to share with you today. Okay, so the first part, we are going to cover about the most common location that complication frequently occur, which is the nasolabial fold. Okay, and then we will have a case discussing about ocular complications. And also, right now, skin quality injectables, whether it is a filler, okay, or maybe biostimulator, may cause vascular complication as well. So we are going to share with you so many cases, but please remind that do not take photograph or video during the session, because there are a lot of patient cases and some cases still ongoing right now. Okay, so let's start with the first case. So we are going to talk about the first complication, which is the nasolabial fold. We have so many experts in the field. All the panelists will join the session today, and they are going to discuss about how should we approach the complications and how should we tackle these complications. The first case.
Yeah, before we begin, I really like to emphasize that there are a way that we can actually approach conventionally by using the highlights, doing at the area that you have necrosis. And we also doing a lot of intravascular and also with the intervention. So we will share the cases that we do interventions, like the new way that we're treating a vascular occlusion, and we see the protocol.
Yes. Okay, so the first case is actually not our case. It is a case report that has been reported, so many cases in the literature. However, you can see that this is a patient, a 50-year-old male. He has done a filler injection using sharp needle on the zygomatic arch and also infraorbital foramen and also nasolabial region. You can see that around 2 days or 48 hours after injection, he started to feel pulsating pain in the right infraorbital and nasolabial area. And you can see from the skin examination, you can appreciate some redness, reticulate erythema, and also development of pustular formation on the injected area. You can also see that when you see this patient, you already know that this is a vascular complication, most likely to be arterial compromise, right? And the conventional treatment that has been reported is doing hyaluronidase injected pulsely, injected multiple times, and the key point is to do multiplane injection. From the case report, they did inject by using 25G cannula all over the area that has a complication. They inject 5 units every hour, total 3 doses in a single day, and follow up on the next day and do additional round of Hyalase. You can see that this is the first picture on the left-hand side. And after pulse hyaluronidase injection without ultrasound, without interventional radiologists, you can see that there's still improvement. However, there's some slowly progress. Okay, the lesion tend to improve over time. And in this case, fortunately, heal without scar. So I want to ask the panel, how much dose you use of Hyalase for each round? Or what is the selection dosage that you choose in your personal preference for each case?
Professor?
Can you hear me now? I think so. Okay, look, the blind approach, basically we use as much as we need to use and as frequently as we need to use it. Every 15 minutes, up to 1,500 units. In Australia we have that sort of vial of 1,500 international units. And you really want to look at capillary return from a non-ultrasound
Yes.
perspective. If you have an ultrasound and you can see disruption of flow, bizarre vascular flow, then you can do ultrasound guided and use as little as 100 units or what have you if you're adept at doing that technique. But as you can see, I don't think you use ultrasound here and you've got a great result. So I
Yes.
think it's very successful. The issue is don't stop, use as much as you need, and don't be frightened of hyaluronidase.
I think the question is whether, what would be the maximum doses that you would go with the Hyalase? And how would you, do you have any like an idea? Because sometimes when we do pulse Hyalase, like we look in the journals, it doesn't really completely help the patients. Will you go higher, and how often do you do, and what is your limit, and how will you decide when will you stop?
Exactly what I wanted actually to address. Because I think actually that in this case, Hyalase did not change the natural course of the disease.
Yes.
Keep in mind always that some patients will recover without
Right.
hyaluronidase.
Yeah, that's
So
right.
the main question is, what is your target point? So if you make a diagnosis during the injection, when you have this kind of blanching, you inject hyaluronidase, whatever the dose you choose, the blanching is gone, this is the end of the treatment. You don't have to pulse and to continue. So I do continue if the blanching was not addressed. So I inject a second dose. And to tell you the truth, I'm going to the maximal, because the maximal concentration, that the amount of hyaluronidase that I have in my country still, it's the British brand, Hyalase, it's 1,500. So for vascular, I inject the maximal. Now the problem is the treatment which takes place after 48 hours.
Yes.
So it's not blanching anymore.
Yeah.
It's diffuse redness and it's inflammation. So I do not expect it to disappear even if I address the HA clot completely. So what are the endpoints for me in this case? It's actually the pain. Because in this stage, the patients are painful. And I don't expect the full discomfort to disappear. Remember, keep in mind they're already inflammation. Inflammation is not addressed immediately by hyaluronidase. But I expect the patient to report that he or she feels more comfortable. And I inject as much as required. So it can be, and I will show it in my case, in posterior temple and alopecia.
Yes.
So I stopped, this my case, the patient was treated on day 3. So again, it's a challenge because it's very hard to tell what is your endpoint. So for me, the endpoint in this stage is pain. And I inject hyaluronidase up to day 5. After day 5, I think that it's useless. The ischemia started already. Then you have to take care of wound healing. Don't inject hyaluronidase, is useless. This is my opinion.
Do you have any different comments?
No, I think the one comment I want to add is there is no highest limit. I think it really depends on the severity of the case. Because if you have a very severe case with a blocking of a main vessel, then you have to add more and more in the first up to 5 days. I'm completely with you. But you have to see them, I see them like twice a day, 3 times a day, and add more, depending on the pain, depending how it looks like after the injection. So I think to maximize the units is a mistake because severe cases need more. If you have an ultrasound, you can be more precise. I'm completely with you. But I think if you have no ultrasound still, you need to inject more. But Marina, yes, go on different things. PRP, I have a case like this as well with alopecia and different things to add after 5 days latest, I think.
I just want to add a comment regarding ultrasound. Because we're all, I think, in this stage of adopting oilies, thinking about adopting ultrasound, and I really believe that ultrasound is useful. But when we are treating ischemic events, you can see the bolus of HA. You cannot see the small emboli of HA by ultrasound. So I yet believe that the clinical condition is the main guidance when you treat ischemic events. You will not be able to find small, minimal doses of HA dispersed in different collateral arteries. Don't trust ultrasound only. You can see the disappearance of the big bolus, but not the small ones. It's very hard to demonstrate them in ultrasound.
Well, do you have any comment? Because what I want we to discuss is whether, well, we know that ultrasound is useful, but whether it's important, it should be like, in everyday practice that we should like having the ultrasounds, or, we just don't need ultrasounds, because we know that ultrasound is useful not only when treating complication, but when we treating the patient, it also, give very a comfort feeling, and particularly in some country, if you can use ultrasounds and you don't use ultrasound, but when the patient have complication, you can easily get sued, because there's a way that you can prevent the complication, but you don't do it. So that's why I want we to discuss, whether the ultrasound is important, for practice, for treating the complications. But if we don't have it in some practice, like in Thailand, we don't really have that many. So how would you successfully, treating, complication of the patients in case like this? First, okay, we don't have limit of high-less. So that's the conclusion that we have at the moment. So we don't have a limit of high-less. But what else that you do,
For me, when patient got vascular compromise, definitely high-res, if it is from HA, high-res is the hero, and then I just, flush in multiplane of injection until I look for the signs of the color, as we all agree. Second one is the pain, the sign of pain and symptoms of pain. The pain from inflammation, the pain from vascular compromise is a bit different. When you test the patient, if you get some inflammation or some pain from needle point, the patient will feel like it's horrible. But if the point that the vascular compromise is there, the patient sometimes when just touch it, they just jump up like that. So that is the sign and symptom that is a clue for me to go on and put more high-res in that area. And also I follow up the patient. If the next day, such as the patient pustule came up on the second day to the third day, right? Depends. And once we see the pus, it means that hypoxia is there. So we need to treat with high-res. But after we treat everything, if everything has been clear, the pus should not come up anymore the next day. But if the pustule still develop, that's another clue for me as well. That is the clue that told me that I need to flush more high-res. And I totally agree there is no limitation for the dose of high-res. No, agree. Oh.
I borrow your microphone. Thank you. A couple of issues here. The use of needles versus cannulas, prevention. When we use high-layers, I agree with Marina, pain is a very important thing, pallor is a very important thing, livido reticularis is an important thing. These are all signs that the patient, these days when we inject fillers, they have lignocaine in them. So pain is often masked. You don't often see the pain. You'll say to the patient, look, I think we have a problem here, but I'm fine, doctor, everything's good. I feel fine. You sure there's a problem? Well, look, there is a problem. And doctor, you're looking a little bit pale. Are you okay? No, I'm really worried about you because you have a problem. But doctor, I trust you, everything you said. But I remember how I warned you that rarely you can get an occlusion. But doctor, I trust you. I feel fine. listen, are you okay? Can you get the nurse to look after you? You look like you're going to faint. Do you need to lie down? You know, often the patients, I've had this experience where they think they're fine. And you really have to say to the patient, look, this is not good. I need to treat you. I need to use hyaluronidase. And by the way, how are you with bee stings? You know, all these things, we're anxious because we can see the problem. And of course, hyaluronidase is a vasodilator. And so the issues can get confused. For me, livedo reticularis is a really important sign. Capillary return is a very important sign. I don't think we're going to get away from ultrasound. I'm not a fanatic about ultrasound, but I know with all these wonderful little devices that we now have, we're all going to have ultrasound in our clinics like we have a stethoscope around our neck. And,
Yes.
you know, it's not just the bolus. You're looking for improvement in vascularity, which you can see. Good ultrasonographers, people who experience can see these things. So this is a complicated issue, and it goes right back to prevention. Needles versus cannulas. I don't like needles in this area.
Yeah.
My goodness, the infraorbital artery sits under there. With collateralization, it just doesn't come out of the foramen. It runs along the periosteum. And you're in there with a blind needle, 27 gauge, I think.
Yeah.
I've used cannulas in that area. I think that technically they are. I've never had an occlusion using a large cannula, and I did have problems using needles.
Ronald, I have a question. You know, I'm playing around with my HS always before starting to inject them to my patients. So I did multiple times the simple test. I put my hyaluronic acid and I just pour around hyaluronidase. And I'm measuring how much time does it take until the gel becomes a liquid. I just want to prepare myself that if something bad happens, how much hyaluronidase I have to inject. And I can tell you that I don't understand really these videos that we all see from hyaluronidase injection under ultrasound. It's gone immediately. It's not the real thing that I said, and I just suggest you
Well, I think the
play
ultrasound.
around, take your hyaluronic acid, put a lot of hyaluronidase, and just measure the time until it becomes liquid. This is what degradation
You're
means.
talking about in vitro, right? You're talking about outside.
Outside, yes.
Yeah. But in the body, it's a different scenario, and I think that the ultrasonographers who are really good look at revascularization. And I think that's really important. I don't think we're ever going to get away
I think
from it.
that part of it is vasodilatation.
I don't think that we are going to retreat from ultrasound, and I'm not a fanatic about
No.
ultrasound, but I think ultrasound is going to be the stethoscope that we all carry, and I'm not for ultrasound that much.
No,
So
Ronald-
I'll be quiet now.
Trust me, I use ultrasound.
Yeah,
use
we
in my
all
practice
do.
ultrasound.
We all
The-
learning.
No, but the thing is, what happens when the clinical picture does not correlate to your ultrasonic
And I agree
image.
with you, Marina. I agree.
This is the
I'm
thing.
going to speak over you because you speak
Clinics-
over me all the time, and you. But I think that ultrasound.
Yes. Let's
Ultrasound.
go,
Oh, okay,
let's
you got
go
another
to
case.
the new
I
cases.
agree with you.
Yes. Let's go to the new cases that we are using ultrasound, helping to treat complications. And then you see whether you want to, do your practice without ultrasounds or with ultrasounds.
Okay.
Alright, yes.
So let's move on to the next case. This is actually the case from our center. This is a 50-year-old female. She has been injected with HA filler on the nasolabial fold and also on the mid-cheek. However, sharp needle was used and also cannula was used as well. You can see that after, Okay, this is 10 hours after injection. She started to feel pain and tenderness and also ecchymosis on the treated area. And however, you can see that the lesion extend to the nasal area on the nasal ala. She has been referred to our center, and on examination that we already see pustular formation on her nose. Personally, I use ultrasound all the time because at our center we have ultrasound both large machine and also portable machine. We did ultrasound in this case and we can see HA filler, you can see an aqueous material here on the bone. And also you can see that the vascularity on the affected area slightly decreased comparing to the other side. So what we did is that we did hyaluronidase injection by ultrasound guide, and we try to inject directly into the vessel. You can see the flow of the color flow of hyaluronidase entering the blood vessel on the nasolabial area. And sometimes you do not need to inject Hyales directly into the vessel. You can just only embed the Hyales around the vessel is enough, because there's a paper published about injecting Hyales around the blood vessel. It can diffuse into the vessel wall, right? But however, we try to incubate into the vessel and inject around the vessel by using ultrasound to target the vessel that we see. And we also dissolve the residual HA material on the nasolabial area by inject directly into the pocket of HA, as you can see here. And we also do subcutaneous layer injection all over the area, flooding all over the nasolabial fold. However, on the first day, we did not inject so much on the nose. And we also did hyperbaric oxygen therapy, LED, and did all other medications. Oh, what happened? Oops, what happened? I'm not touching anything. Okay, what happened? Can our team check the slide? Okay. Okay, but you can see that in this case, since I would say that in our hospital we use ultrasound around a year and a half. Yeah, and since the first day that I used ultrasound, I never stopped using it. Once you see more, you get more, you have more information, I think. Yeah, it's better to know something than nothing, right? Yeah. I will show you more. I will try to persuade you to use ultrasound more.
Because, you know, if you don't have ultrasound, then you go with 12,000, right? The number that you show.
Yeah.
Yes.
Yeah.
But with ultrasound, how much do you use?
Normally, I would say that before the ultrasound era, we opened our center for many years now. Before ultrasound era, we tend to use very high amount of Hyales per case until we finish the case. Sometimes
Yeah, 100,
you
yes.
see, right? The 20, 30.
So we actually do it until it's completely revascularization and no pain and no numbing, nothing. I mean, completely normal, almost completely normal. The pain score will be 1, and then for pain score 1, then we stop doing the Hyales. So, you know, maybe one day we use like 100 bottle, 100 times, 15, 100 unit. That's a lot number of Hyales that we use in severe case.
I would say that when we see underneath the skin by ultrasound, you know exactly how many units that you need to treat that area. Let's say if you want to dissolve the HA filler that compress the vein around that area, you see that you already inject and it's already there. There's no need to inject like so many amounts of
You don't have to
units
inject
in
surround,
that area. You just that goes directly into the pocket of the problem. Yeah.
So
if you want to look into this case, there are 2 more comments, I think. One is 0.6 ml in a canine fossa is a lot of material. For me, far too much. Only the material can do a compression, and only the material can have this outcome with no vascular compromise in the beginning. Second, I truly think we not necessarily need to hit the vessel if the material is in the vessel at all, because many times it's only a vascular spasm which leads to the blanching and leads because of too much material, because of an internal reaction. So I think you have to be precise with an ultrasound if you have it, but if you don't have it, just don't hesitate. Just also add hyaluronidase, and you will get rid of the spasm of the perforated veins and vessels easily.
yes.
I think that's a great comment, Dr. Sattler, and I agree with you entirely. I think a lot of this is spasm, and relieving that spasm usually resolves the problem. You don't have to be intravascular. I think that's pretty hard to do anyway, even with ultrasound.
Very hard.
However,
We can do it.
I think that what we haven't brought up in this case is pre-mapping. So we know that we can have 2 arteries in that region of the sulcus here, and mapping is very important because you might have a vessel. We assume there's no vessel on the periosteum, but you can have a vessel there. You can have a superficial vessel as well. So a few seconds of mapping can prevent a lot. And again, needle versus cannula. We can have a whole seminar on that.
Yeah.
I happen to like cannulas a lot, large cannulas. because I think prevention of this problem is much better than treating the problem.
Solving the problem.
Thank you.
That's right.
Yes.
Because I totally 100% agree that safe mapping is very essential right now, especially if you have only portable machine in your hand. You can do safe mapping, especially the area that you want to do blind injection still using sharp needle on the bone. So you already know that anatomists will agree, Dr. Benrita will agree that you can see some deep vessel deep down to the bone in that area, right? So it's better to do safe mapping by using ultrasound. I will move on to the case. Okay. After I did ultrasound guide HILS injection, this is the result. You can see that the area that we treat around the nasolabial fold area, the reticulate erythema around this area improved. The patient feel less pain in this area. However, we did not do any treatment on the nose. You can see that it's still going on. The process is still getting worse. The patient's still getting worse. She still feel pain on the nose. However, on this area, she tell that the pain score is decreased. So I want to emphasize that ultrasound may help. When you do ultrasound guide intra-arterial injection, it may help in around the territory that the major large vessel the HILS will go around. But in some area that, like when the vessel have to turn around in the corner, it may not completely go in that direction. So conventional HILS injection inject into the skin, into the subcutaneous layer is still essential. I think combination between conventional technique and ultrasound, with the help of ultrasound, it would be better than using ultrasound or conventional treatment alone.
Yeah, increase efficacy.
Yes, I
So
totally.
please continue.
Okay, so I did ultrasound. You can see that there is a decrease of blood flow on the nose area. Okay, so right now we change our treatment regimen. We inject directly into the nose, and also inject all over the area and do pus removal. After injection, you can see the return of the blood flow. The blood flow start to show up. You can see in the Doppler color mode, right? And this is the result after 1 day after. You can see that there is no new pustule formation. The patient feel less pain right now. Okay. We did ultrasound follow-up every day. You can see the improved echogenicity of the skin. It start to heal and also increase of the blood flow every time that we do. So we do another round of HILS, but not ultrasound guide right now. We inject directly by using conventional technique, multiplane injection. You can see that 7-day follow-up. You can see improve echogenicity of the skin and also improve the blood flow. This is the result after 7 days.
All right.
I want the first injection of hyaluronidase was performed by cannula, right?
You mean by using ultrasound, right?
Under the ultrasound, but it was cannula
Sharp needle.
assisted injection of hyaluronidase.
We used sharp needle. Inject
Sharp needle.
directly into the vessel. Yes.
No, because I was thinking that usually when I use sharp needle, I infiltrate superficial and deep. It might be a little bit more problematic if you inject with the cannula as the bolus injection with hyaluronidase, then the skin is not affected at all. And then you need to add on the intracutaneous or subcutaneous injection.
Yeah.
Because it's a very nice presentation. Actually, the subcutaneous vessels need to be addressed as well.
Yes.
Yes.
That's a very good point.
Yes.
Actually, there is one more case. I will show you later.
Yes.
Okay, so I think that ultrasound we are entering a new era right now. Ultrasound will be in your clinic, in your hospital very soon. And you may need to learn by starting learning right now. Actually, I started learning ultrasound last year, and you can see that last year I have no knowledge of ultrasound at all. And 1 year passed by. I started using it by practicing it every day. And because I'm lucky because our center is a referral center for complication case, so I do it every day and solving problem every day. So you can see that you have to start learning and you learn something from it. Okay, so let's move to the next case. Okay, next case is quite a little bit more challenging. 28-year-old female, she has reticulate erythema on the cheek and upper lip after HA injection. She has been injected on the nasolabial fold and on the lips. by using also sharp needle and cannula as well. I will show you the picture. And 2 days after the injection, she started to have symptoms and go to the clinic. And doctor that injected her in the clinic evaluate that might be an avascular occlusion. And initial management was done, oral anticoagulant was given, and the doctor inject Hyalase by using conventional technique, multiplane injection. However, the patient still have new pustule formation all over the area that has been injected and referred to our center. She has pain sensation on palpation, and this is the clinical picture. You can see that this case is quite severe comparing to the previous case, right? The area is quite extensive. You can see that the reticulate erythema extending from, the worst part is on the nose, the lips. However, the reticulate erythema extend to all over the cheek area. So this case referred to our center. We are very shocked. Oh, what should we do now? This is very extensive. So we did ultrasound and we see that there is an increased perforating vessel around the occlusion area. However, the occlusion area, the vessel vascularity is very silent. So we think that this might be a severe arterial occlusion from HA filler. We actually did ultrasound guide intraarterial injection as an initial management that we done. However, we consult in our team, and actually we are very lucky in our team that we have a radiologist, interventional radiologist in our team. And we have so many experience in dissolving filler in a large area. So we think that if the area is very extensive, we may not be the best person to help this patient. So we may need the help with our panelists in here อาจารย์ชัยนะครับก็คือ so we consult interventional radiologist to help us do filler dissolution in our case. So อาจารย์ชัย will share นะครับ his experience on this case. Okay.
Thank you. My voice is a bit lousy because I'm just recovered from catching cold. So sorry. Until now, we don't have a standard in the large area. How large is we consider large? So we get consult from the dermatologist in case that the area of infarction involved, for example, lip and nose. Okay, if just lip, maybe we will not touch it. In this case, how do we treat it? As the neurointerventionist, mostly my job is to treat the brain stroke or aneurysm and the head and neck as well. In this particular case, we evaluate the area of infarction of the skin. Then we put the catheter in the facial arteries, and we will check the area of distribution of the vessels. In this particular case, you see that the right superior labial artery is occluded, and the contrast, the area is diminished. That's then we put the smaller catheter in the affected branch, and then we infused Hyalase. During infusion Hyalase, we will check the capillary refill and the pain of patient as well. If they report that pain decrease and the capillary refill less than 2 seconds, then we stop. So we infuse more. Otherwise, we will infuse more and more. And maybe sometimes we go to the other side, on the left side, even it does not show in the skin, to cross the midline to treat the skin.
Yes.
That's it.
Okay, and the next slide is...
Yes, yes.
Dr. Shai, yes. Dr. Shai.
So this is a picture that you inject the
Yes,
Hyalase,
it's
right?
15,000.
Okay.
Right.
Okay, and after injection, you can see the improvement of the blood flow by real time. Okay. So we admit the patient in the hospital for 1 day and do other treatment for her. And you can see that 1 day after the treatment, there is no new development of a new lesion. The old wound start to dry up, okay? And then we did ultrasound and follow up every day to monitor the blood flow. There is still some decrease of the blood flow, so right now we just do only conventional hairless injection multiplanes. We use 18 vials. You can see that if we do not use ultrasound, we inject blindly, we tend to use a little bit more amount. Okay, this is follow-up after. We did the same thing. We did all over again. And this is result after around 1 week. You can see that the wound starts to dry up. However, in this case, the necrosis area is very deep, so the patient ends up with a scar. Okay, this is the result last day that she visited our hospital. So you can see that if the area of involvement is quite extensive, sometimes you may need a help with a good friend. Okay, so you can see that besides from conventional injection, ultrasound may be your best companion. However, interventional radiology may be another interesting option to help with a patient with extensive involvement of skin. Okay?
So the question is, our question is, will you consider the intervention radiology guided for a high-res in severe extensive case? Do you consider using it? You think it's useful?
I don't know today. Because for me, the question in this case, whether it was really improved by therapy or was it a natural course of the disease. Keep in mind, we started to inject hyaluronidase 20 years ago, maybe a little bit less. And before that, the main area